So let's start. Good evening, everyone. Today is the last day of our webinar titled "Health Issues of Underprivileged Women," organized by Internal Complaint Committee and IQAC of the Haldia Government College, and in collaboration with R.U.B.I Society and Research Center, Howrah. On behalf of the organizers, I, Dr. Shoumide, once again welcome all of you. We are actually discussing from yesterday on a very important issue, and health issue is always very urgent and important of any gender bias. So today we will continue our previous discussion, and we have two speakers for today, Dr. Anindita Chaudhuri, who are from Psychology Department of University of Calcutta, and Mrs. Suchandrima Bhattacharjee, who is one of the member of R.U.B.I Society and Research Center, and also a part of Calcutta Samaritan. So let's start with our first speaker. First of all, welcome, Madam Dr. Anindita Chaudhuri. She is also my teacher and co-guide of my PhD work. And Dr. Anindita Chaudhuri at present is working in the Department of Psychology, University of Calcutta. She completed her master degree from Calcutta University in Psychology and awarded UGC Junior Research Fellowship in 2000. She completed her PhD in Applied Psychology from Calcutta University, then joined Ashutosh College as a teacher, and later on in 2006, she has joined Calcutta University as assistant professor. Her interests and teaching area include social psychology, identity, self, happiness, and well-being. She has completed 4 research projects of UGC and ICSSR. Dr. Chaudhuri has published 30 papers in national and international journals, and she has guided 10 PhD scholars. Now I request Dr. Chaudhuri to deliver her lecture. Madam, please take over the microphone.
Thank you, Shoumi. Thank you all for this invitation. I hope I would be I would restrict my lecture within the stipulated time. I will try to finish it within that time period. So today, my lecture, I like to tell stories. So I will begin with, just a moment, let me present. So just a moment. I'll take just a moment from you.
No problem, ma'am. Take your time. Right side corner, present now.
I'm searching it. Just a moment. Yes, I have actually just a minute, please. I'm actually struggling with its presentation. Yes, I can see. Yes, 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 I can see. But uh, it's not showing actually. That's why. Okay. Show me. I'm sending you the slide. Can you share it on my behalf? Because
Yes,
otherwise
ma'am.
it will be late.
Yes, ma'am. Yes, ma'am. No problem.
Okay. I have sent it to you. Well, let me start, and Shomi will be sharing the slide on my behalf. Well, I like storytelling, and when I thought about uh, giving a lecture on identity of women and well-being, because I am from the background of psychology, so to me, health issues calls for mental health issues, or you may say the concept of well-being, happiness, life satisfaction, and how one feels about her or his life. So uh, it we may say that Shomi, can we have the slide, please?
Ma'am, preview is not available and download is not possible
Okay,
because
just okay. Give
you
me
have
just
used some different software. So
no. Just now,
it's not working.
I will send the next one. Uh,
Okay.
just just give me. Yes, yes. Sorry for this technical problem. Just I will send it in a while. Just a moment. Show me, I have sent you the PDF version of it. I think now it will be easier for you.
Um,
Have you received the mail?
no, not yet.
Okay. Uh, shall I carry on with my?
You can carry on.
Okay, okay.
I will.
Thank
Yeah, I got it.
you. Okay. Uh, Now, when I thought about talking about women well-being, uh, their identity, it came to my mind that currently I am researching with a section of women who are engaged in commercial sexual intimacy. And as all of us have come across the mentioning of these women, this section of women who are engaged in commercial sexual intimacy, and there are various terms they have been labeled as since time immemorial. Like they have been called as gonita, they have been called as veshya, bar bonita, hooker, prostitute, or sex worker. So when I thought of them and about their identity, their well-being, their resilience, I started to delve into the lived experience of these sex workers, some of these sex workers, and a team. We are as a team we are working, and I am going to share my research experience and what they uh, think about themselves, their well-being, their identity. And when I thought about these women, it reflected to me. You heard few of the short stories written by eminent Bengali author Bibhutibhushan Bandyopadhyay. So you may ask me why you are talking about the short stories by written by Bibhutibhushan only, because in literature, in maybe in other forms of creative expressions, there are so many stories, so many anecdotes, so many accounts that have been written about these women. Why I have mentioned some works of Vibhuti Bhushan as because I feel that Vibhuti Bhushan is one person, one author who depicts the characters, the protagonist in a way just like the the way the empathy is about the characters are shown in the short stories or are expressed in the short stories are like unparalleled, I must say. That's why I have selected three stories, and I will name them. One being Hinger Kochuri. I think many of you have read this. One is Giribala, and the other one is one short story named Bipod. And the characters depicted in this story, like Kushum from Hinger Kochuri, Giribala from the story Giribala, and Haju from the story Bipod, and all of them were quote unquote sex workers in their profession. But their life experiences were different, and their journey as a sex worker was also different, and their journey uh, after this life, after this few years into this profession were also different, and how they felt about their lives, how they felt about their existence, their well-being, and how they related with the people who are around them, and how they identified, how they interacted with the people who are out there. So, in Hinger Kochuri, we can see Kushum, this character, in two phases of her life. The little boy who used to go to Kushum out of the greed of having this Hinger Kochuri, which her babu used to brought, used to brought, and later on, when this boy, when he was a grown-up man, when he encountered Kushum, when she was like quote unquote retired from this profession and into a different kind of profession, he was working as a domestic help in a mess. In Giribala, this story, this Kushum and Haju, both these characters, where they were into these brothels, what we say, that they were like having their own small houses, mud houses, or that kind of houses where they used to stay, and they used to like engage into this commercial sexual activity. Whereas Giribala was kind of different from them, because she was from a village, and she used to stay in that village, and she she entertained customers from her own village. But later on, this Giribala turned into a guruma who used to who became a kind of spiritual leader or a spiritual person who was into this entirely into this spiritual and religious experience, and who became the one and only person who used to help the downtrodden of that particular village. So how was the experience of these women? These were depicted in these short stories. Now, if we come to this identity part, because I have thought of this lecture into, I have I have merged the concept of identity and well-being into it. Like, what is identity? How can we explain what is identity? Identity can be a singular identity, it can be a plural identity as well. As because the way we appreciate, we evaluate ourselves, that like the attributions or the attributes we have, this can be considered to be a individualistic or a singular identity. But each and every one of us do possess a multi-layered identity, because our existence is multi-layered. So each and every one of us definitely has, other than singular identity, we do have collective identity. And this collective identity can also be termed as a plural identity. Like the way we play the various roles in all the stories, we can see, like I was talking about Kushum. Kushum was a very affectionate lady who used to love that little boy, and her dilemma in whether to give food to the boy who was from a Brahmin family or not, the dilemma of being a sex worker. Similarly, Giribala, like the way she considered herself, and Haju, who was a downtrodden girl before joining this particular profession, and now she is happy with her life because she can earn money, she can send money to her mother, and she is the thinking about bringing her child in a satisfactory way, I should say. So these are the various layered identities of us: the identity of being a woman, possibly, the identity of being a mother, the identity being of a person from a village or from a city. There can be so many different types of identity: our ethnicity, our class, our caste, religion, so on and so forth. This identity can be real, this identity can be imagined as well, because the what I'm saying is about all the intricate nuances of the identity, what the identity theorists have provided us. So I can identify myself with any other people also, because in my group we can think about myself as a person who is distinctively different from others, whereas we can feel a sense of shared oneness or we-ness with others. Like being a member of the same nation state, we all feel that we all are Indian. That is a collective identity. But being say being Kushum, being Giribalak, being Haju, or XYZ, that is an individualistic identity. And this identity, it does not simply exist, rather, it continually formed and reformed. It is shaped and it is created, it is shaped, and basically, it is being formed and reformed, created and shaped by discourse of the individual and those who are around them. And owing to the nature of it, or rather, I must say, owing to its dialectical nature, it is both individual as well as collective. And through identity, social categories can be created, like I was talking about this ethnicity, gender, nationality, religion, which signifies the multi layered existence of our identity. And basically, our psyche, our mind is the seat of this uh, imagined community or the communion, like my ethnicity, my gender, my nationality, my religion. So the what I was talking about, this woman, the woman about whom I am talking about, we can say, like, just like when we consider people to be marginalized, say in terms of financial aspects or otherwise, we can think about people being marginalized in terms of identity as well. Like, I will straight away go to one of the very powerful theory, what I feel, that of Finney's theory of ethnic identity. Though this particular theory was created to explain how ethnic identity is formed, and it formed and it is being maintained. But I feel this can be extended to other areas as well. To Finney, it is about the identification, like Finney is talking about this identification with the majority or minority group. We can think it, you can juxtapose it to other areas as well. Like, according to Finney, this identification with the majority, whether you being in the majority group or you being in the minority group, whatever it is, this identification with the majority or maybe with the minority group can be of two types. That is, it can be strong or it can be weak, both with majority and minority group. And we can see in practice, in reality, there can be like this identification thing can be like one can have a very strong identification with the majority group, but maybe there is a strong identification as well as with the minority group. I can define it in this way, that if it- because it was done, this particular research was done with black people and white people in US. So like the people who are strongly identified with the majority culture of the particular nation state, and as well who can imbibe in them the strong ethnic identity of oneself as well, who may be in the minority group. This is one group. And like we can say they are actually accultured or bicultural people. There can be people who are who have identified very strongly with the majority group, but who are very weakly, who have identified themselves very weakly with their minority group. They are the assimilated people, and the people who have the strong ethnic identity but very weak that majority or majority identity, they can be said that they are ethnically embedded. Finally comes the people who cannot identify them with the majority or with the minority group. They are the marginalized. So it is all about marginalization of identity. These people, though the people who are from the downtrodden class and whose background may vary, till now, till date, their background may vary. Either some of them are, they have come to these places for commercial sexual intimacy owing to maybe trafficking of women, or maybe some of them are into this profession by choice. Whatever be the background, we can say that they consider themselves, and not only that they consider themselves, it is the mainstream society at large who consider themselves to be marginalized. And we can say this in terms of identity also, we can say that there can be people who are marginalized. So the sex workers whom we are talking about, definitely they have a marginalized identity. Now, what about their well-being? I was talking about Kushum, Giribala, and Haju. There are so many. There can be so many names. I am like using fictitious names from short stories, but they do represent the women who are into this profession. Now, what about well-being? In Indian context, from Indian psychological context, uh, we talk about happy and unhappy life. Like happy life, we call it Shukha Swarup, and unhappy life we call Dukha Swarup. In Indian psychological context, as it is considered that shama, or avoidance of extreme, or maintenance of balance and equilibrium in all functioning, should be considered to be the core of happiness. Non A kind of non-attachment and maintaining the balance or equilibrium and avoidance of extreme is the core to your happiness. Now, what about the Western perspective? Western perspective considers well-being uh, as the kind of experience of a kind of pleasant emotion experience that includes pleasant emotion, low negative mood, high satisfaction in life. And this well-being has two different aspects, one being happiness, the other being life satisfaction. Happiness is our affect, our emotion, whereas life satisfaction is the cognitive evaluation about our life. So, what about these ladies, these women, whether they are having good subjective well being or not? Dimension wise, well being can be said in one theory, it has been said that what who can be who can be considered to be a person who is happy with her or his life, who is having a good well being. It is said that if the person can accept herself or himself, if the person has positive relation with others, if the person is having autonomy, is autonomous, independent, having environmental mastery, and with a purpose in life, if all these aspects, all these dimensions are high, we can say a person is having good well-being. Now, the women we are talking about, do they have this well being? Let us talk about it. First, self acceptance. Self acceptance talks about the positive attitude towards self. In our research, what we have found is that uh, most of the women, most of the ladies, for various reasons, they have entered into this profession. They a kind of dilemma is there in terms of self acceptance. When they uh, consider themselves to be the single bread earner of the family, and when they focus on the financial aspect of it, they feels good about themselves. When they see that their family is having a good life, their children are having good education, their parents are well fed, when they focus into these aspects, they think that, well, what they're doing is just like another profession, another job. But there is a dilemma because um, at times, and many a times, they do feel dissatisfied with themselves because of the disappointment they have, uh, the kind of stigma that is being attached with the profession, the way people evaluate, people judge about this profession, and the way they have to hide their profession from significant others in their life as well, creates a dilemma. So there is a dilemma in terms of self acceptance. Like dilemma, I won't say there is a dilemma, but I would say that in terms of self acceptance, there is a duality. Duality would be a better term to explain it. Like at times they can accept themselves, at times they cannot accept themselves. Now, having coming, if we come to the next point, that is positive relation with others. uh, in professional life, they do have positive relation with the people who are around them. And if to for some, they do have positive relation with their family, but again comes this dilemma, this duality in terms of the hiding of the profession, because in many of the cases the family members don't know about this particular profession they are into. In some cases their family member do know that, but in they are in a constant worry, constant anxiety that whether, if known to the people who are around them, if it is known that they are into this particular profession, that is commercial sexual intimacy, how they will be evaluated, or they will be, whether they will be ostracized, whether they will at all be able to go back to their home or not. And outside this particular area, they at times feel unsafe. They either they are safe when they are into this their like workplace, or they are safe when they are at home. This is the dilly dally they usually face. And regarding the autonomy, autonomy calls for self determination, independence, resistance to social pressure, and at times it also becomes difficult. Now, I was talking about environmental mastery. That is a sense of mastery, sense of competence in managing the environment. Um, Definitely, at times they feel that they have mastered, they have this environmental mastery in, as because they feel competent in managing the environment, in the sense they have managed very well the financial aspect of their life. They do have a plan, like till when they are planning for planning for this like saving kind of thing, like they do say that we are here for few years because I need to have money for like my household, for my future of my children, future of my parents, maybe future of my siblings. And that's why I'm here, and I can control my environment. So partially what I can say is that they do have this environmental mastery. Now coming to the last point, that purpose in life. So what about this purpose in life? Purpose in life, as we all know, that having some goals in life, a kind of focus, a kind of directedness, and uh, like when we talk about our meaning in life, that why we are living, why we are like, what is the meaning of our existence, when we question us, we do have a certain definite answer, and we do have certain definitive life goals. So for these women also, they do have a sense of meaning, a sense of directedness, a focus, and many of them are focusing on particularly this financial aspect, that this uh, profession is providing me with this financial comfort which was lacking in my earlier life. So def- this focus keeps them going. Okay, so if I try to, this is the reference, like I am like, it is an ongoing study conducted by Nilanjana Mitra, Professor Ronald Paul Hill, Professor Roy Chaudhuri, and myself, and the female sex workers we have interviewed, we have come across to these aspects that I was talking about, the financial aspect, and whether their family will accept them or not. Time and again, these harps into their mind, and time and again, these thoughts come to them, their future thought, how they are defining themselves. Like, we do have a certain value. Like, sometimes it is, they do have this this thought that for us, for people like us, you people are safe. Like, they, when talking about other women in the society who are not marginalized in terms of this commercial sexual intimacy, because they are into this commercial sexual intimacy, they are marginalized by the society at large, maybe in part by their family. So this is an immense pressure to resist. So, how they define themselves against this immense pressure? At times, they define themselves in this way: I am into this profession so that I can take care of my family, I can take care of my children. So, it is entirely the financial aspects that keeps them going. And they define themselves in this way that, see, I am like becoming a buffer who is actually safeguarding you people out there. So, definitely, I am not a person to be eyed upon. Definitely, you should not have stigma against me. Definitely, you should have some level of appreciation or evaluation, or I must say, some level of respect for me as well. So, at times, they define themselves in this way. And like I was talking about throughout the lecture, it is all about identity. So I was talking about this shaping, this creation, reformation of identity, reformation of psyche. So it calls for a kind of interchangeability as well. So in these women, I have noticed that to them, there is a certain type of interchangeability in their identity in terms of acceptance of oneself. Um, and finally, coming to whether how are they, and whether in terms of well-being and identity, whether I will say that their well-being is very high or not, no. As because you can see that most of the areas, most of the dimensions about self-acceptance, about um, mostly about self-acceptance, there is a duality, uh, but the purpose in life is present, environmental mastery is present. So it is a kind of mixed state of these women, I must say, who are into commercial sexual intimacy. So, like, finally, if I try to wind up what I have said, um, from the writings of Bibhuti Bhushan Bandyopadhyay, because uh, his stories, those who have read all these short stories, they can relate with it easily. But those who still not have read it, um, uh, I will request them to read this story so that you can see how the author feels empathetically about these women, these marginalized women, these women toward whom the entire society have a stigma, how the author have penned like a mother the life stories, the experiences of these women, and finally like coming to the life of Kushum. At the end of the story, you can see when this little boy who comes back to Kushum searching her. Kushum again from her meager income, she whatever she have, she buys hinger kochuri for this little boy who is a grown-up man now, who is a middle adult now, buys hinger kochuri and serves him. It expresses her affection, her transcendence. In the story of Giribala, how Giribala finds the meaning in life, like how helping the poor, downtrodden people through the spiritual way. And in case of Haju, who is still young and who is into the business or profession currently, how she feels about herself, like she can buy things for her, she can send money to her mother, and she can think about think about the way she wants to brought up her child. So I would say this is the transcendence, this is the purpose of life of these women. And in a final note, I would say that definitely well-being in terms of popular notion, definitely this self-acceptance, maybe there is a duality in self-acceptance, but this what I have said, that this Shukha Swarup, definitely they do have a duality, they have many repentances in their life, but they have some way, I can say that they have transcended, and they have kind of maintained a balance in thought, sham, what I was talking about, in their thought regarding whatever they have experienced in their life and what they want to do in the coming days of their life. Thank you. Uh, any queries? I think I'm into time.
Thank you, madam. And it was a wonderful presentation. And I'm very much interested in this type of topic. And I have also worked with you regarding identity issues. And today's presentation is wonderful. And now I hand over this session for the interactive session to Monami Dash Roy. Monami, please take over the microphone.
Hello, madam. I am Dr. Monami Dasra. Very nice presentation, and thank you for sharing your knowledge with us. We have a question from Dr. Srimanta Das. I think he will ask the question himself. Srimanto, please ask the question. Okay.
Yeah, good evening, everybody. First, I must thank Dr. Anindita Chaudhuri for her lecture on an extremely problematic issue. However, I have a question for you, ma'am. Well, we are aware that prostitutes means, as you have phrased it, means who are, say, in this profession commercially. Well, they are conscious of their marginalized status, but I guess they are also seen as a diseased group by the larger world. How does that affect them, say, psychologically? I mean, in a way, they are seen as moving cases of various STDs, which may be true, which may be not, but doesn't this affect their sense of identity?
Thank you. Thank you for the question. Like the people who we interviewed, they are very conscious because of maybe the work that has been carried out for last 20-30 years. They are very conscious about these sexually transmitted diseases. And thank you for this question, Dr. Das. Like when we interviewed them, they have expressed their concern about this also. And because many of them, like you cannot even imagine the way they have expressed themselves in these terms. Many of them are mother of the children. So for their children, they want to be safe. They want to remain safe. And they do have a certain kind of idea about, a very clear-cut idea, I must say, about their body. So there are two things. One being they have to be healthy so that they practice safe sex, and they insist to their clientels that they do have clientels, and they insist their clients to practice safe sex. This is first and foremost thing. And the way somehow this training of practicing safe sex and this the knowledge that has been imparted to them, it has changed their idea of self also, the body also. Now they do know about the right of their body. And I have come across this concept about the right of the body in the sense that they do refuse the clients to do certain practices, sexual practices, as because they want to remain healthy. And it is benefiting them in two ways. One, they are actually much more safe. And when they think that even my client asks me, force me to do this kind of sexual act, I will not do it because it is my body, my right. Definitely, it has a positive impact on their identity, I must say.
Thank you so much, ma'am, for your answer. So, over to Monami, ma'am.
Okay, thank you, ma'am. Another question is from Mr. Sandeep Kumar Kabi. Just a minute. The question is, an uneducated but unaware or physics patient, about what such social context change their views?
Could you repeat the question once more? I didn't get it properly.
Uneducated but unaware of or physics patient, about what such social context change their views?
What patient? Uneducated. It's about their level of education and awareness.
Hello, I think that is a psychic patient.
I
think the word is
unaware or psychic patient.
Okay, I mean, I think the question has the connotation being whether they are being forced into this particular practice, and whether people having lower level of intelligence are also whether they are being forced into this practice or not. Is that the essence of the question, Dr. Dashwar?
Yes.
Okay. See, since this study we are doing is in Kolkata, it is a Kolkata-based study. So the women we have interviewed, we haven't come across any woman who is not unaware about this profession and the pros and cons of this profession. So it is informed. They are aware. They have been getting the knowledge of how to practice safe sex. What are the pros and cons? That's what I was saying. So if we say that whether they're definitely 20 years back, we can see the people, many women who joined this profession, say 15-20 years back, many of them were like trafficked women, and some of them have joined by choice. But nowadays, nobody, like the women we have come across, nobody have joined without their without their choice. Many of them have, those who have joined, they have joined this particular profession because many of them are from downtrodden class. Mostly they are from downtrodden class, and they have joined this profession because of financial what should I say, financial prospect. And they are planning to leave this profession after like saving a certain amount of money. So there, we haven't we haven't come across any women who are not informed or who are not aware about this profession. And about this psychic patient or having low intelligence, no, we haven't, like in our research, we haven't encountered such women or such person, such people. Is that
Yeah, thank you, ma'am. Just a minute. Another question is there anything government doing to support or protect these sex workers?
Many NGOs are working. Many NGOs are working. You know that in Kolkata only, Durbar, I am naming the organization, they are like doing, you know, commendable task. And definitely, I'm not very well aware about the government policies about these things, but in India, I'm not sure. Shomi can correct me, or Saurabh is the right person to correct me. I think doing sex work has been decriminalized. Is that Saurabh? Saurabh, are you listening? Uh, it is decriminalized. So from but lot of work to do. Lot of work to do because yes, Saurabh. Hmm. Problems of these, yes. And as you all know that this in this lockdown period, they are suffering a lot. They are suffering a lot. Many of them have went back to their ancestral places, but um, what will happen to them afterwards? Like they are also facing financial crisis during this time period. Definitely government has to come forward. There so many things needs to be corrected, needs to be addressed, so many things, so many aspects. But first, from like as a psychologist, what I can say that first try to ward off the stigma. First try to consider them as a human being just like us. In many of the countries in the world, in many of the like developed countries of the world, sex workers are taxpayers, just like you and me. I, being a professor, I pay tax. A sex worker also pay tax. We are at the same platform. So first of all, what we need is that, like, from a societal level, definitely government has to come forward. But from a societal level, we should consider them as a human being just like us. Try to ward off the stigma from your mind, from our mind. That's what I must say.
Thank you, ma'am. Show me. Now it is to you.
Thank you, Monamidi. Thank you, madam. It's a wonderful presentation, again, I must say. And one thing, uh, uh, I have a question in my mind that at the time of my dissertation paper in MSc, I actually worked on the sex worker for few months in Sonagachi. And that time I noticed there are some categories of sex workers, and they term themselves as A category, B category, C category according to their age groups. Okay, so do you think is this type of identity or this type of ethnocentric feeling make them more vulnerable for in terms of mental health, or they suffer from poor well-being for this kind of identity?
Got your point, Shumi. It's not about mental health. I would say, in terms of, if you say in terms of identity, definitely it is. I must say, when these categories are linked with, say, excellence, if I say, or say the time that is left for me to build up my future. Mostly, it is about a very futuristic, I must say, a very futuristic plan drives them. Otherwise, definitely it is not acceptable. This kind of profession is not acceptable to many of them. That's why they feel that I have to leave this kind of job. I need the money, I have to save it, and then I will leave the job. Just like many of us think. What I feel is that identity, in terms like evaluation, if I connect self-evaluation with identity, definitely it is um, going to push you in terms of the way you are evaluating yourself. That whether I am at all good into this profession, or I will be able to make I will consider in that way only, that whether I at all I am acceptable, I am suitable, and I am more efficient or not. In terms of that, if you say identity and whether their well-being will be hampered, well-being definitely is connected with self-acceptance and self-esteem, high self-esteem. Definitely, if I feel that I'm not that good, there can be like, if you accept yourself that way, it will enhance your well-being. And if you cannot accept yourself in that way, definitely it will decrease your well-being. So, uh, categorization, I will say, well-being can be differentiated by these two ways. The way you are accepting it or you are not accepting it, definitely that will have some impact on the identity.
Okay, ma'am, thank you. And thank you for this wonderful deliberation. And now I request the next speaker, Mrs. Suchandrima Bhattacharjee. At present, she is a coordinator in state level coordinating agency of the Calcutta Samaritan. She completed her master degree from Calcutta University in 1997 in anthropology. She joined Calcutta Samaritan, a national level NGO, in 2000. This NGO works in collaboration with Ministry of Social Justice and Empowerment of GOI. Her interests include the field of treatment and rehabilitation of drug. Mrs. Suchandrima Bhattacharjee is also an executive member of RUBI Society and Research Center. Now I request Suchandrima ji, please take over the mic and deliver your lecture.
Thank you, Shomi. Am I audible to everyone?
Yes, yes, you are audible.
Thank you so much. And it's indeed a great privilege to be here presenting on the women drug users who are so very marginalized and discriminated. Thank you, Haldia Government College and the organizing committee and everyone who is present in this seminar for listening. And before starting, I would just like to mention that this working with Calcutta Samaritans for the past so many years, the things that I will be saying or presenting is my sharing of experiences, as I have found the women drug users in our treatment center, that is of the Calcutta Samaritans, as I found them, and it's just a sharing of experience with you all, just to show their state, how they are. Let me just share the presentation. Is the presentation coming?
No, it's not visible.
Yes, one second.
Just press the present now button. Yes.
Yes, is it coming? Is it coming? Show me. Show me, is the presentation being seen?
Yes, yes, it's coming. Yes, ma'am.
Show up. Can everybody see my presentation?
It is
Okay.
visible.
Okay. Okay, one second.
Please carry on. It's okay.
Is it all right? Show me.
Yes. Please carry
Okay.
on.
Okay. First, before talking on drug abuse and drug addicts, I just want to mention that drug abuse, drug addiction is a disease. The first thing before we enter into a discussion on addiction, we should remember that addiction is a disease like any other disease. And the disease is a chronic disease and very prone to relapse. So, when we are talking about women and drug abuse, we have to see the woman from three perspectives mainly. Women who are non-drug users, they do not use anything, but they have drug abusing families or their partner. We call it partner, it might be his husband, boyfriend, anyone who is a drug user. The second category are those women who are consuming drugs. Okay, drugs here means both alcohol and other drugs, whatever are the categories. And the third category are those women drug users who are also partners of male drug users. Now, coming to talk on women drug users, this group is a very hard to reach group. You just cannot find them. And it's really a painstaking job to get them. It's because you cannot find them in numbers, in surveys, in treatment facilities. And here I would like to point out that in India, throughout India, in our country, there are 450 treatment centers for addicts, which are run by Ministry of Social Justice and Empowerment Government of India. But there is not a single center for the female drug user. Okay. The second is that there is where you can also find this within the household, where women always have whatever a woman might be, but she has a whole lot of family responsibilities and family obligation. That is her first and foremost duty that she has to do. Now, often these responsibilities makes her feel her own needs, her own necessities is at a lower priority to everything. For a small example, you will find in your house your mother, wife suffering from common cold, fever. Okay, they will say, no, no, it's all right. It's all right. It will get well. I'll take some medicine. It will be all right. Unless, and they will go for treatment unless that thing amounts to a severe condition. So, in this case, also, it comes at the health of a woman comes at a lower priority. And when this health issue is related to drug dependency treatment, then there is a very big question mark. Then comes the most important obstacle, that's the social stigma and discrimination. Due to this social stigma, I will ask you a question. I see people when there is, if a girl is found smoking in public, I find people staring at that girl. Why? Why is this discriminatory attitude? Because from the very beginning, society has taught us that for a girl, addiction, smoking addiction is a very big no. So, and addiction is always a man phenomenon. So all these things leads to social stigma, discrimination, and when a woman is using drugs and she feels that if I expose myself, if I say that I need treatment, or if anyone comes to know that I am a drug user, then my family will be shunned, and even the family sphere. I have found lots of families coming to a treatment center and saying that my daughter is an addict, but can you please give us some medicine so that we can cure her at home? My dear, this cannot be cured. This is not just medicine that is required to cure addiction. There is a total program, and everyone should go. Any addict, a person who is an addict, needs to go through this program. So this fear, this social stigma and discrimination are major barriers that why they do not open up, why they do not come up in official statistics. Talking about women who are non-drug users, but they have partners who are drug users. Might be the husband is a user. Sometimes it might be the son might be a user. So in this case, the whole family becomes stigmatized, becomes discriminated because of the use. People label them that he is the wife of a patakhor. Pata is the colloquial term for brown sugar. And they label him wife of patakhor, wife of a thief. So this kind of stigma and discrimination is labeled on the family. If there is a drug user in the family, then the relationship dynamics changes. Financial resources comes down to zero. There are plenty of families who were well-to-do families have gone down to bankruptcy because what happens when there is a drug user in the family, his need for drugs, he will create pandemonium. He will create pandemonium in the household, domestic violence in order to get money for his stuff. So what happens? That on one side, the financial resources of the families gets depleted, and on the other side, this person has to be given treatment. The family ultimately realizes that he needs treatment. So again, they have to invest in treatment. So the whole family comes at a stake. All the relationship, the total family condition comes at a stake when there is a drug user in the family. Then sexual relationship between the husband and the wife, that suffers, and there is a risk of the wife, if it is the woman partner, there is risk of HIV and other bloodborne infections, STIs, because you may not know that this drug user might be, he's an injecting drug user, he might be sharing, he might be carrying the virus, he might be the carrier of a virus. Now when he comes home and he has sex with his wife, and that is also unprotected sex. Okay, even if he wears a condom in the state of intoxication, the process of wearing a condom is pretty difficult. Somebody please turn off the microphone. So it's pretty difficult. So in state of intoxication, the person cannot even wear the condom properly. So all these issues, and goes for unsafe sex. So what happens? The woman, the female partner, is at risk of HIV, STI and other bloodborne infection. And this is one of the reasons how the virus, the HIV virus, is being transmitted also among the general population. And bearing with this whole thing, drug user in the family, you have to, this creates a severe effect on the woman, and where she has to bear a significant part of the family burden. She has to handle, on one hand, she has to maintain the family, on one hand, she has to look after the drug user. So her life is at stake, is at a mess. Now, there are certain uniqueness of women drug users. Here, I'm talking about the women drug users who are using the drugs, who are taking alcohol or other drugs. Now, women, from the first initiating into substance use to the development of drug use disorder, this is a process. Initiation till drug use dependence is a process of growth. This, for women, this comes very faster than men. And this is called the telescoping effect. Then, women have a greater susceptibility, like addiction, drug addiction, comes along with a number of medical problems and psychological problems. So, serious medical problems arise. Now, in case of women, these medical problems, they come very early than men. A very special health issues that is related to women drug user is related to infertility. Women that I have met in my center complained of being infertile, having repeated abortions, spontaneous abortions, stillbirth, affect the total menstrual cycle becomes changed, and there is also a high chance of fetal addiction. Fetal addiction is when a woman is pregnant and she is under the influence of AOD. AOD is alcohol and other drugs. AOD. Then it also happens that the newborn baby has withdrawal symptoms of the drug that the mother has used. Withdrawal is certain symptoms. Withdrawal symptoms are certain symptoms that when a person stops taking the drug that he is dependent on, suddenly stops taking the drug on which he is dependent, stops it, the body, what happens, the body, I would say the body goes against it, and uh, these are called withdrawal symptoms, and withdrawal symptoms are different for different drugs. So this kind of withdrawal symptoms are also found in the newborn baby. Uh, a high proportion, majority, many women users who have come for, whom I have met during my course of work, they have complained. They have said that they have faced childhood adverse situations, like most of them have experienced traumatic childhood situations, experienced domestic violence. Might be one of the parents was a drug user. There has been instances of sexual abuse, molestation, physical abuse. So, and these are certain vulnerabilities that when experienced in childhood, this creates a risk factor for the woman to being addicted to drugs. Another important issue is that significant relationships and play a very important role. Family history play a very important role in initiation and pattern of use of the woman drug user. Here I would just want to mention a small case study. Relationship. I had found a woman who had come to our center. She was a brown sugar addict. So she told us that when she was pregnant, she used to suffer. She had a lot of problem regarding pain. She used to have pain during the initial stages of pregnancy, vomiting. Those are the usual symptoms during the initial stages of pregnancy. So this woman said that you will be shocked. She did not know that her husband was a brown sugar user, and this woman, her husband said that you use this substance, use it in this way, it will give you relief. So what happened? Husband gave her the substance, she used it. Brown sugar is a opiate group drug. So definitely the sensations of pain and everything due to the effect of the narcotic analgesic group of drug it is. So she got relief, and then she had a bit of sleep also. She felt good. This feeling good factor. She felt good. So this feel good factor uh, made her take the drug quite often. And ultimately, she landed up in treatment center. There are certain studies that have shown that women use start their initiation into drug use at a much later stage than men, and their substance use is very strongly influenced by their intimate partners who are also drug users. Women, when it comes to drug abuse, I have told you the amount of stigma and discrimination, and you all know about this, that the amount of stigma and discrimination. If someone comes and says that this lady who might be your next door neighbor comes and says that this woman is an alcoholic, so suddenly your image of that woman will change. So definitely women. So in that case, family support for treatment comes at a much later stage. There are families that I have found they have come for treatment, but they are reluctant to take back the patient after she has undergone her treatment, and they are uniquely stigmatized and discriminated. Among women, the women use all kinds of drugs, but mostly the use of tranquilizers, sedative drugs, and opiate drugs. Opiate, the group which we call as the narcotic analgesic group, is the main things that they use. Majority of women use this apart from alcohol and other drugs. And gender-based violence. When in a family, I would like to share another thing. I don't know whether I'll be able to finish my presentation, but one small thing I would like to mention. A lady once told me that a boy can use I'm saying this in Bengali. ছেলেরা তো একটু নেশা করবেই, নেশা না করলে ছেলে হয়, but woman, no. There is a big no there, because again, our socialization process has taught us that addiction and woman is a big no. And because of this gender-based violence, whenever a small study, I have found this woman on the streets of Kolkata. She was a drug user. And she told me that when her family came to know about her using, they simply threw her out of the house, and she was out on the street. And this is the condition. There was another lady who told me that she has 2 daughters. She was on the streets. I met her on the street. That she told me that she has 2 daughters, and both the daughters are married. And so I said that, do your daughters, do they know that you are staying on the street? And then she said that they know everything, but they have told me that I should not return back home, because if my son-in-laws come to know that I am a drug user, then their family will be at stake. So this is the situation. Now, talking about the stigmatization, as I have said, that this stigmatization of women drug users, because they are doing something which is outside the social norm. Women, their behavior is not something which is at par with the society. Society doesn't accept a woman using drugs, and they are doing that. So the stigma is so severe that they are even looked upon as women of bad character. This goes back to their character also. People think that they are women of bad character, and and they can be used. You can use them at any place, at any instance. They have no character because they are drug users. Now, as I told in my previous slide, that male partners frequently shape the woman's pattern of drug use. Now, as I told that mostly majority of women are initiated, whom I have met, majority of them have been initiated into drug use by an intimate male partner. And if like the dependence is such that they, even if they are an injecting drug user who inject drugs. So this woman, they are like, they have to ask their male partner, they ask their male partner to inject them. And even there are cases where she cannot ask for she knows that sharing, might be she knows everything, that sharing makes her vulnerable to HIV and other bloodborne diseases. She knows everything, but she cannot negotiate with her male partner for a clean needle, for a clean syringe, or say no to sharing. Because that will portray what? Mistrust, unfaithfulness. Now you might ask me that why can't she do it on her own? The stigma, discrimination is so vast that she doesn't have any support system. If you visit women drug users on the street, you will find the precarious situations they are in. The police, the local goons, they are subjected to exploitation by the police, the local goons. So in that kind of circumstances, what happens? It is the male partner to whom the woman drug user looks forward for support, because they feel that if anything happens to me, he is there. The male partner is there to look after. And this feeling of stigma penetrates such deep down that these women feel that I'm a woman of a lost character. I do not have what more worse can happen to me. If you go and speak to them that why don't you you know that sharing is bad, and if you go to them, all if you talk to them on these things, they will say that what worst can happen to me? I am a drug user. So this is again an effect of stigma, because they feel that the society has stigmatized them to such an extent that, and this penetrates such deep down within them, that they feel that nothing bad, I'm a bad woman, nothing more bad can happen to me. I've been thrown out by my family, I have no one. So what, even if it is HIV infection, doesn't matter. So the sharing continues, unsafe sexual practices continues, unsafe injecting practices continues. Women have less control over the men, over how, from where the drug is being brought, the injecting equipments are there. Now, drug, if you are injecting the drug, it is not only the syringe and the needle that matters. There are also some other paraphernalias, and we always say that those that is the cotton, the cooker, the water, everything, nothing should be shared. But women injecting drug user have less control over this. This is all dictated by the male. And in most situations, the woman is injected after the male partner. The male partner injects the drug, and then the woman is injected. She is second on the needle. So you can well imagine that how the vulnerability towards infections increases. Now, as I said, that the male drug user is a dominant factor in this group. The male partner who is using drug is dominant, because he arranges for the food, he arranges for the, most importantly, he arranges for the drug, because this woman is a drug user. Once she needs drugs to maintain herself. She needs, once the withdrawal sets in, she will be in a terrible situation. So this male drug user mainly provides for this drug, brings the drug. So, and many a time, this being dominant in this relationship, this male drug user often compels the woman to continue using the drug or discourages her from seeking treatment. And in this kind of situation, what happens is that, as I told you, that negotiating for safe behaviors is almost impossible. And if a woman refuses to have sex or negotiate for condom use, this triggers violence. And many instances, my dear friends, women who are using drugs are compelled to sell their sex in lieu of drugs. They sell their sex, they go for sex with the male drug user, and then she gets a share of drugs. Now, many women, like these sort of women, now many women who use drugs, for them, the very quick mode of getting money, very flexible mode of getting money to buy the stuff is working as a sex worker. In this case, because of the disease of addiction, she knows that unless she buys the substance and she uses the substance, the withdrawal will set in, and withdrawal is a terrible pain. So what happens is that she doesn't negotiate for safer sex. This negotiation for condom use or negotiating for safer sex, because of this urgency to get the money, to buy the drug and to push it in, becomes so severe that she goes for unprotected sexual intercourse. Now, women are, as I said, who are using drugs are more vulnerable to HIV, hepatitis C, and other bloodborne infections. And because of all these reasons, because of her incapability of negotiating for safer sex, safer injecting practice, all these things makes her more and more vulnerable to HIV and hepatitis C. Women who are using drugs during pregnancy, as I told you, that the health of the newborn is affected. It leads to serious pregnancy complications, the low birth weight, spontaneous miscarriages, premature delivery, and neonatal abstinence syndrome that I said, fetal addiction syndrome that I said, that infants are born with withdrawal symptoms of the drug that the mother is using. Mothers who are using cocaine during pregnancy, are babies born to mothers, are they have seen to have a low birth weight, a small head circumference, and are shorter than those born to mothers who do not use cocaine. In case of cannabis, people using cannabis, I mean gaja, chorosh, bhang, all these things, during pregnancy, there is a manifold increase during pregnancy. If a woman uses the cannabis related products, there is a greater risk, or the risk of stillbirth increases multiple times. And babies, the newborn, displays altered response to visual stimuli, trembles. So these are all the withdrawal symptoms of cannabis again, for cannabis withdrawal. And mothers who are suffering from, mothers who are drug users, definitely they undermine the health and development of their children. And most importantly, over here that I would like to mention, that Children are neglected because the mother, who is the main caregiver in the family, when the mother becomes involved or is preoccupied with the drug, when it is in case of an addict, okay, the cycle, his daily routine is in a in a triangle. It's engulfed in a triangle. He thinks about when to procure the substance, how to procure the substance, and when to take it. So similarly, when mother, who is the main caregiver in the family, is into drugs and she is preoccupied with addiction, then the safety, security, children, development of children becomes a second priority. And this is also an important risk factor for initiating use among children. When children see that their mother is using the substance, out of curiosity, parental drug use is one of the main reasons for drug use among young people, among young children. So this acts as a, not only is the child's health, well-being neglected, and the child itself is neglected, but this is also an important risk factor for the child in getting initiated into drug use. Now, the challenges that are faced by women drug user, that is, they have lack of information and access to health services. They are not informed. They do not have access to health services, including HIV/AIDS prevention and care programs. Lack of gender-sensitive services. This is very important challenge. Lack of gender-sensitive services. That includes, there is a lack of female service providers in the treatment centers. Family support. Lack of family support. And the hidden drug use, they try to hide their drug use because, as I said, because of the fear of social ostracism, cannot negotiate for safer sex, because they are marginalized by the society, discriminated by the society. They feel that we are powerless. They suffer from self-pity. They suffer from low self-esteem. And as I told you, that this guilt feeling, because of this marginalization, because of this stigma, this guilt feeling penetrates deep down to such an extent that they feel that they are worthless. And their chronic health problems, their sexual assault, chronic health problems, as I said, that drug use comes along with a lot of medical problems, and women are escalate into those problems much faster than male. On top of that, there is family violence, there is sexual assault, there is adolescent pregnancy, and malnutrition. Malnutrition is another important. They need money. Whatever money they will get, they will go to buy the stuff. Might be whatever they have earned, that goes to buy the stuff. So to them, the disease of addiction is so severe that the desire for that, the hunger, it is the hunger for the substance, not the hunger for food. A small thing you will find in the platforms, the children using dendrite Fevicol. I think you all have encountered children using dendrite Fevicol. One of the main reasons why these children do this is that they help, these Fevicol dendrite, they help to cope with the hunger. These children do not feel hungry if they take it. So this is a very painful situation. In a nutshell, the scenario of the women drug users, this is all that I have already said. Yes, now coming to the treatment part. This effect of, you will find, as I said, that in our country there are 450 treatment centers run by the government, but not even a single one is for the woman. So this shows that what kind of stigma and discrimination, because the number doesn't come up. Women drug users are so hidden group that the number doesn't come up in statistics. Whatever family resources are there, if there is a girl and a boy, the family will try for treatment of that boy, and for the girl they will try to hide it. They will say that please give us some medicine so that we can treat her for home detox. And another thing is that, as I told you, that because of this stigma and all this discriminatory attitude of the society, it is sometimes the woman feels that what will happen? Something worst has happened to us. Nothing more worse can happen to us. So we are over here, we are fine. And they are not much motivated for treatment. Now, there are certain barriers also. One important barrier. What are the barriers for the female drug users to access treatment? Like, one barrier is stigma and discrimination. They do not want to come out with their problem of addiction. They do not want to acknowledge their problem of addiction. Another barrier is that these treatment centers do not have any, they do not have any child care facility. Now, most of the treatment centers, now it is a 30 days residential program. You have to stay there. So, most of the cases, what happens that the woman doesn't want to stay for such a long period because she has her children. So this is an important thing, that child care center should be integrated with the Center for Female Drug Users. Now, on one hand, there is this lack of service, and on the other hand, this hiddenness, this punitive attitude prevails among the family members, among the woman drug user herself, and this fear that she might lose custody of her child. One story over here, I had met this woman, and she said that she was a drug user. She has 2 children, and she told me that I cannot come for treatment because if I go for treatment, then who is going to look after my child? So when we told them that, when we told her that now, in fact, how are you looking after your children? You are using drugs. This is more detrimental to the development of these children. She said that at least I provide for the food. I look after them, even if I use, but I have no one. I have no one who is going to look after the kids were small. So this is one important thing, that this child care responsibility of woman contradicts with her treatment. Another one is that inflexible admission. Like I said, that treatment center, you have to stay there for 30 days. Admission procedures require family members or a sponsor, because you need to sign bonds and everything. So all these things makes, and the schedule, 30 days schedule, or might be that is the detoxification, and then there is a 6 months rehab schedule. So all these things doesn't suit, many times doesn't suit the needs, the responsibilities that a female has, along with her drug using, along with her need for taking treatment for drugs. A major hindrance comes when the woman drug user has a male partner. This male partner, if you have to give treatment to a female drug user, this I have experienced. If you have to give treatment to a female drug user and she has a male partner who is also a drug user, you have to treat the male partner first. You have to provide treatment services to that male partner first, because otherwise he is going to demotivate the woman. He will not allow. There was this woman who was very motivated. We went and spoke with her. She was ready to come. The next day at 10 o'clock, I sent my female outreach worker to get her. When the female outreach worker came back and told me that she was saying that that at that time we were having a project by UNODC, and which provided free treatment facilities for the women drug users. So she was enrolled in that free treatment facilities. Even in that case, it was a free treatment. Mind you, it's a free treatment. Even in that case, the female outreach worker came back and informed me that she will not come, because even if it is free, she is not going to come, because unless you give treatment to the male drug user, the male drug user is demotivating her. And she is saying that what will happen if I take treatment? I will be there, I will leave drugs. Again, I have to come back and stay with him. So if he is not treated, I will again relapse. So this is one very important obstacle. And yes, in societies where we see we consider a woman taking drug as a woman of bad character, in that case, it becomes our cultural norms, what we have learned since childhood, that addiction is no to woman. This cultural norm within us also makes it difficult for the woman to acknowledge that, yes, I am a drug addict. I need a treatment for my addiction. So this barrier is an important barrier, and the present treatment scenario that I would like to present, I feel that all should have a look at it. Services are not gender responsive, and they do not cater to the special needs of the woman. As I told you, you will find hardly treatment centers for the female. Lack of treatment centers for the female drug users. And another important barrier is lack of female service providers in treatment centers, because these female drug users, when they come for treatment, they come along with a lot of trauma, a lot of pain, a lot of problems, which at that time they are not comfortable to speak with a male counselor. So, but female service providers there is a lack of female service providers in this field. And in fact, as I told you, that there are no child care center integrated with treatment center. But however, there is a big ray of hope that from 2020, from this year 2020, the ministry has made provision in its National Action Plan for Drug Demand Reduction. The ministry has taken up, uh, has made provision for opening up drug dependence treatment center for the female drug users. And they have already started two programs, that is the outreach drop-in center. Outreach drop-in center is that the outreach worker will go to the field, talk with the drug users, both male and female, so that at least the woman comes, at least we can find the woman, at least they do not hide, becomes hidden. So, and the community-based peer-led intervention. So these three programs have come up, are coming up. I shouldn't say have come up, but they are. The last two have come up. Outreach drop-in center and community-based peer-led intervention is on the go. But this opening of drug dependence treatment center for the female drug users, ministry has opened up proposals, asked NGOs to give proposals for opening up such centers, even asked the government hospitals to set up the addiction centers, and this is a bit ray of hope. Thank you.
Thank you, Suchandrima. It's a very nice presentation. Now I request Dr. Shimonto Das to take over the session of to take over the interactive session. Shimonto Das.
Good evening, everybody. Thank you, Dr. Abhishekta Bhattacharjee, for your rather enlightening.
1 second. I would just like to interrupt you. I'm very sorry for this. My name is not actually Abhishekta, is my daughter's name. I don't know how this has come up. I mean, I have opened her mail, but this mail was made to me and I have opened it. So that's my daughter's name. I'm Suchandrima.
Okay,
Anyway,
okay,
continue.
I'm extremely sorry, ma'am.
It's all right. It's not your fault. It's anyway. Continue, sir.
Okay, I am thankful really for your lecture on, say, such a problematic issue like drug abuse. So this is the question answer session, and the first question for you, ma'am, is from Antara Dhar, and she has asked a very interesting question actually. Is there any link between, say, nuclear families and drug use?
Sir, can you be a bit louder? Can't hear.
Ma'am, I'll just repeat the question. Is there a link between nuclear families and drug use?
Nuclear families and drug use.
Means, is it more common, say, amongst the members of a nuclear family? Does it work like that?
No. I don't think that the nuclear families have a link with drug use, because I have found many families. Actually, the main cause is that healthy family relationships is very important. Parents giving time to children, be it a nuclear family, be it a joint family, whatever it might be, but a healthy family relationship, healthy parental relationship, parents trying to know about the activities of their children, parents talking to their children, spending quality time with them, not quantitative time, but quality time. This is important.
Thank you, ma'am, so much for your answer. The next one is from Mr. John Paul Xavier, and his question is, in spite of so many monitoring mechanisms, why is there no decline in the number of drug users?
Yeah, this is a very, as first only I have said that drug use, addiction is a disease, and a disease which is very prone to relapse. Okay. See, and the national the standard for relapse rate is more than 70%. Means if a treatment center, for example, if a treatment center is giving treatment to 100, 70 people will relapse because this is the nature of the disease. It's a disease. When we are going to acknowledge this disease concept, we understand addiction as a disease, then only we can understand now that it is a chronic and it is relapsing in nature. So government, so in spite of so many awareness programs and every now ministry has started, you can always go to the site of Ministry of Social Justice and Empowerment and you can see Nasha Mukt Bharat Abhiyan. This is a campaign that has started throughout India, but still, because it is a disease, it is addiction, there is relapse, and that is the 70% relapse is the normal rate of relapse. So this is difficult. It is increasing, but we still try that at least the harms associated with drug use. This is the main thing, that we are trying that there is no new entry into the drug, which we called as primary prevention. No new entry into the drug, and trying that those people who are into addiction, at least they stay away from the harm, which is the harm reduction strategy of drug abuse.
Thank you so much, ma'am, for your answer. Ma'am, now we have to move to the next question. Well, this person hasn't really written his or her name, but the question is rather interesting. You see, in Indian
So
society,
would you please a bit louder? I think some problem in the connection. Yes.
Yeah, yes, ma'am. I'm trying my best, ma'am.
Yes.
Ma'am, according to this person, means there are not too many drug peddlers around. So, means how do the women get access to drugs, particularly in say in Indian society?
Please repeat.
Ma'am, there are not too many drug peddlers around. Means they are not easily visible. So, means how do women get drugs? Means how do they get access to drugs, particularly say in an Indian society?
See, this is a very this is a very wrong notion that people who are using drug, who are addicted to drugs, they know that where peddlers are available. You will never know. I don't know from if you, for example, a small example, if you go to Shialda station, okay, I don't know whether you are from Kolkata. If
Yes,
you go to Shialda station or Howrah station, okay, you will not be able to locate peddlers, but peddlers are roaming because peddlers are roaming there. But we ordinary people, as we are not into this, we have a good strength of recovering drug users. So one of my friend who was also who is a recovering drug user had told me that there was a time when there was a crisis of brown sugar in Kolkata market. So what did he do? Can you imagine? The news came that it was available in Orissa. So the next, immediately he packed his bag and he went to Orissa to buy the stuff. This is drug addiction.
Okay, ma'am. This sounds frightening. Actually, it means people go to such extremes to get access to drugs. I guess.
Exactly. You won't know that. One of my colleagues also said his father died. His father died, and his withdrawal started. So what did he do? He did not have his stuff. His father, the dead body was lying. He went, brought the stuff, injected it, and then came back and did all the whatever the work needs to be done, the cremation and all the things. This is the reality.
Okay, ma'am. Ma'am,
Yes.
the next question is actually from me. Means this is something I really want to know about.
Yes.
Don't you think, ma'am, most of the first-time users are from, say, urban colleges and universities, especially those which have, say, hostels with them?
Sir, no, it's not that. This staying in a urban setting, we feel that the college students or the school students are the first users. No, as I told you, I have seen users who are from a rural background, who are from a real rural background, from Mushidabad, from Medinipur. They are drug users, and quite at a later age, not school college goers. Yes, school college goers are there, and this is basically the male drug users. They start off early, from 9, 10. They start off you from cigarette to ganja, then after ganja go to alcohol, occasional using. But in case of female drug users, this is not the pattern. Means I did not find.
Okay, ma'am. Thank you so much, ma'am. I guess then the next one is going to be the final question, because this session has been,
Yes, sir.
say, a long one. Ma'am, this is from my colleague Gautam Bhaumik from Haldia Government College, Department of Economics.
Yes.
And well, his question is whether the problem of a woman's drug addiction associated with female education, are the two things correlated?
Female education.
Is it more common among, say, less educated women, or say, is it more common among, say, more educated women or highly educated?
No. Addiction has, sir, addiction has nothing to do with education. There are illiterate people who are using drugs, and I have seen, and there are highly educated people who are also drug users. Addiction has neither to do with educational background, professional background, and also sometimes we do say like this, that he is financially so stable, so he is using because he has money. We always say this, that because he has money, so he has lots of money, so he is using. No, there are many people who are using. They don't have money, means they don't have bank balance, but this is the disease of addiction. It's a disease. If we acknowledge the disease concept, then we will understand it has nothing to do with one's education, with one's professional life, with one's financial status.
Okay, thank you so much, ma'am, for your time. I guess now we have come to the end of the
Thank you,
session.
sir, also for listening.
Thank you, ma'am. Now I guess it's over to Dr. Shomi. Yeah.
Thank you, Shumanto. And once again, thank you, Suchandrima Di, for your time. And it was a very nice presentation. Yes.
I would like to say one thing. I think I had missed it out, and that's a very important aspect of mine. I don't know whether you have said or not. That is, I'm working with Calcutta Samaritans for a long period of time, since the year 2000. But recently, I'm also a member of RUBI Society, executive board member of RUBI Society. It's a budding NGO. We are trying to work for the marginalized, underprivileged women. We have done a small campaign after this cyclone Amphan, and we have distributed some food items to the villages, and Shomi took an active part in this. And we are also trying to organize a health camp, and I request all of you to bless this initiatives, because our group members are young professionals in the field. Uh, so I would ask everyone to bless us and to help us in our initiative, so that this RUBI society, which is trying to work for the underprivileged and marginalized sections of the society, they can continue the work. We need your patronship. Thank you so much. Yes, Shomi.
Thank you so much, Suchandrima Di, once again. And now we are running late. So I request Sri Pritam Bandyopadhyay to give the vote of thanks. So Pritam Da, it's over to you.
Thank you, Dr. Day. So we have come finally to the end of this two-day international webinar. It was wonderful to be together with such a huge number of you people. And how can I deny that it feels sad when it's time to part? So on behalf of the ICC of Haldia Government College, I will now express our deep gratitude to the four eminent resource persons of this webinar who have enriched us yesterday and today: Dr. Anindita Sengupta, Dr. Arpita Mondal Nandi, Dr. Anindita Chaudhuri, and Mrs. Suchandrima Bhattacharjee. Had they not been kind enough to take time out of their busy schedules and make their valuable contribution here, there would be no webinar at all. We know this best. Next, our gratitude goes to our Honorable Officer in Charge, Dr. Piyush Kanti Tripathi, who, though not being able to be present this time, has been the motive force and source of support all along. We missed you, but we know that even though you are not present, your encouragement and tutelage have been with us. We are further grateful to our IQAC coordinator, Dr. Dipankar Sadhukha, also a co-organizer of the event, whose friendly guidance and reassuring presence beside us always make these endeavors seem easy and worthwhile. How can we not also thank from the bottom of our hearts the other co-organizer, R.U.B.I Society and Research Center, Howrah, whose cooperation and support have made this webinar possible. Two of our resource persons are the executive board members of this society, Dr. Arpita Mondal Nandi and Mrs. Suchandrima Bhattacharjee. I'll request you both to kindly convey our regards to all else associated with you. Next, a big thank you is due to the members of the ICC of this college, whose hard work has showed this webinar the light of day. But a very special mention should be made of the convener, Dr. Shomi De, who it will not at all be an overstatement to say is the principal architect of the webinar. Leading from the front, Dr. De carried it on her shoulders from conception through all the preparations to its successful execution at this moment. We all know that a webinar has to depend on the web, and this requires sound technical expertise, which has been provided to us by Sri Saurabh Dhar, Research Assistant, Maulana Abul Kalam Azad Institute of Asian Studies, Kolkata. We are indebted to him for this help and thank him wholeheartedly. And finally, the participants. It will perhaps be a presumption to thank the more than 1,400 people from as many as 11 countries. Yes, you heard that right. Dr. Shomide also has mentioned it yesterday. From 11 countries who have registered themselves and are actually listening in now in YouTube. A truly global audience, which makes this webinar truly international. Please accept our grateful thanks, all of you, for being there and making our effort meaningful. At the end, therefore, let us all leave with the hope that all the scholarly deliberations and discussions will prove to be effective stimuli for the participants and will blossom into new knowledge and improved health conditions for underprivileged women. Thank you. And it's now again over to Dr. Shomi De for the last words.
Thank you, Pritamda. And it's a wonderful evening we have. And now it's time to officially declare the webinar is over. And finally, I would like to thank Dr. Piyushkanti Tripathi, our officer in charge, our IQAC coordinator, Dr. Dipankar Shaduka, all the organizing committee members, and particularly the resource persons and RUBI Society and Research Center. So thank you, and thank you for the participants, and good night.